Hi guys. So yeah, thanks for having me. I hope you can all see my slides and everything. I can't see anyone's photos, anyone's things, or the chat. So the admin guys are going to keep an eye out on the chat for me. So any questions you have along the way, send them in, and they're going to be feeding it back to me, and I can answer as we go, or I can answer them at the end. So yeah, we're going to be talking about upper limb X-rays. I'm an FY1 doctor at the moment, and my last rotation was trauma and orthopedics. So I saw my fair share of good-looking upper limb X-rays whilst I was there. So we can go through the basics of them today and the common pathologies you might see when you're working. So obviously, as we know, X-rays are going to be essential for diagnosing any fractures and dislocations and joint pathologies. And every single day I was requesting X-rays for patients that were coming in, patients that are on the ward. And even when I'm not on orthopedics anymore, I'm still having to request X-rays for patients who have had falls on the ward or have other injuries that they've come in with. Today we're going to be going through some systematic approaches of looking at X-rays and how we can get a good, accurate diagnosis and not miss anything, and look at some of the NHS, NICE, UK MLA guidelines for management for these. So common views, first of all. So it's important to say for any X-ray that you're going to get, generally, you probably want at least 2 views, unless it's maybe a chest X-ray or an abdo X-ray. Any other limb X-ray, you're always going to want at least 2 views. So if we have a look at forearm, so we have 2 views here. So we have AP and lateral. I'm hoping you can see my mouse. That will help a little bit more. So this is what we call our AP, so anterior posterior view, and that literally looks at it front on. And then we also have a lateral view, which looks at it from the other side. So if we have a little look at our bones whilst we're here, the main bones of the forearm we have are our radius, which runs all the way along here, and we have our ulna, which runs along here. Now, there's not really an easy way, I'd say, to remember which is which. They're kind of opposite to one another. Kind of more distally, your radius is a lot larger. More proximately, your ulna is a lot larger. And here we can see it here, your ulna making up your elbow and your olecranon, going a little bit smaller here, and you've got a larger radius styloid at the top. And then a bit more proximately, you've got your smaller radial head. And that obviously attaches to your humerus, which is down here. And then you have all your carpal bones, which are your wrist bones, a little bit up here. But generally, if we're looking at the forearm, the main things we're looking at in terms of X-rays is just going to be your AP and your lateral. And that helps identify most breaks or dislocations. Next, we're looking at our wrist bones. So we have 3 to 4 views that we tend to take for the wrist. So these are more specific views looking at the wrist bones themselves. So we have 8 carpal bones. There's a mnemonic you can learn to use them, and I just have gone over them over and over and over again, that they're sort of embedded in my head a little bit now, but I still have to think about the T's. So if you go from your radial side, so this is your scaphoid, then you have your lunate, and then you have 2 bones here. If you can see with the eye of faith, you have one there and one there. So here you have triquetrum, that's the 3rd one, so 3 tri, and then P pisiform. And then over here, just under your thumb, you have your trapezium, so trapezium under your thumb. And then next along, you have your trapezoid. Then you have your capitate, which is quite a big one here, and then your hamate, and you also have your hooker hamate, which a lot of people remember. So they're your 8 carpal bones. And you can see them quite well here. This is your lateral view, your PA view, AP view. This is your lateral view, as we saw before. This is your oblique view, so it just gives you a little bit more of a view of the carpal bones themselves without any overlap of the radius and ulna. And here you have your ulnar deviated view here, which is where your hand is moved in a way, it's deviated towards the ulna, and you can see your scaphoid a little bit better just by here. gives you a better view for having a look at any fractures that might be within the scaphoid here. And we'll talk about that, why that's important a little bit later on. Next, you have your hand. So following on from your carpal bones, you have your metacarpal bones, which are these ones right in the middle. And then you have your phalanges. So you've got your proximal, your middle, and your distal. And then obviously in your thumb, you've just got your proximal and your distal. Here, we just have 3 V's again. You have your PA or AP and your lateral. And as well, you can have your oblique view, which can give you a slightly better view of those first few bones, metacarpal joints. And then we've got our elbows. So as we said earlier, we've got our radial head here, which looks like a little bit of a golf top, and we have our ulna, which goes all the way back with our olecranon behind, and that joins up to our humerus, and these are our condyle bones just at the top, well, our condyle processes. And so here again we have our AP view, we have our lateral view, and here you can see the nice elbow hinge joint with our olecranon here, and a little bony spur on that one actually. And you also have your external oblique. So this is an oblique view, again, just twisting the arm ever so slightly more to see better views of the radial head and the condyles without there being as much contact again. So these are the kind of views that we'll get in most upper limb x-rays. So any x-ray that you look at, you're going to want to have a systematic approach, and this is probably going to be most important for your exams, for your OSCEs or your ISCEs coming up. So before you even kind of go to look at the x-ray, buy yourself some time by doing the main things that you always do, which is looking at the patient details and demographics, looking at the type of x-ray it is, see whether it's an x-ray of a hand, of an arm, of a forearm, of a leg, and then also the orientation of it, so AP or lateral or oblique, as we've said. And one of the most important things that a lot of people forget is looking at the date of the x-ray. It's really surprising how easy it can be to look at an x-ray that's from about 10 days ago when someone's come in today with a brand new problem. So definitely keep an eye on that. And as we said at the start, as with all x-rays, if you're handed an x-ray of a limb, always ask for a second one. In an OSCE, they probably won't give you another one, but to be able to fully assess a joint or a fracture or a dislocation, you always want to have 2, because these are just 2D images, and we want to try and see in as 3D as possible. So classic medical abbreviations or acronyms, we're going to do our ABCs for our x-rays. So A is for alignment, so looking at the alignment of the bones. So if we take this x-ray by here, it'd be very easy for us to just jump straight to the main problem here, but we want to do it in a systematic way. So we want to have a look at the alignment. So do the bones generally look like they're kind of in the right place? And at first glance, you could probably say, yeah, they sort of do. You know, your ulna's sort of straight, your radius is obviously a bit straight, but crooked, but generally in the right place. The carpal bones generally look all right, and these are kind of in the right place. You're pretty happy that the wrist looks like a wrist. And then B for bones. So what you want to do is go around the entire cortex of each of these bones. I know it's very annoying to do, but in practice, this is kind of what you have to do. And you go around to see if there's any disruptions. Oh, there's a disruption there. You can see that they're not quite connected. Go around, and then here, there's actually still a little bit of connection there if you use the eye of faith, and you go down. And then you can do the same with all your carpal bones and your metacarpal bones as well. So, okay, for bones, we know that there's some cortical disruption here. We can't really see any density changes, but what we can see is that there are some growth plates in situ. Now, it's really easy when you're first looking at x-rays of kids to think that these are fractures, but actually up until about the ages of 14 to 18, most kids will still have a growth plate intact, and this is where all the growing goes on. So these aren't actually fractures here, but it's easy to think they might be. C, cartilage and joints. So we want to have a look at our joint spacings. So if we have a look at the metacarpals, everything looks pretty well aligned. However, when we kind of get to our ulnar region, we can see there's a little bit of a step here, which if we went back to some of our other x-rays, we probably wouldn't see as well. So yeah, we can see that there's a little bit of joint disruption here in terms of the height of that ulnar versus the radius, but we can't see any signs of arthritis at all. Densities, so in some things we can have a look for any swellings. You could maybe say there's a little bit of swelling here on this person. We can't really see any fat pads or any effusions on this. And then extra findings, so sometimes you might see so a screw in a patient, you might see that they've got something stuck in them, a foreign body, a bit of glass, a nail. See if they've got any form of surgery, so that might be a plate or a nail that might be in their arm. So this is what you want to do for all x-rays generally, and that'll give you a pretty good place of going forward. Okay, so now we're going to move on to some of our common wrist pathologies. So by far, one of the most common distal radius fractures you'll get is a Colles fracture. And often this goes hand in hand with a Smith's fracture, which we'll be coming onto in a second as well. So a Colles fracture is a fracture of the distal radius, and it causes a very classic dinner fork deformity. So it's caused by this here. You can see dinner fork not quite in line. It's a classic fouche injury, which is a fall on an outstretched hand. So often be child or elderly osteoporotic women, they go to fall, they put their hands out to stop them. That wrist makes contact with the floor and they just sustain a break in that distal radius. This is what it looks like on an AP view. So you can, if we did our ABCDE approach, we can have a look at the alignment, but the main thing we look at is the bones here. So we can see there's definitely some breaks in the cortices here. Everything else looks pretty okay. And then from our lateral, we can see that it's definitely displaced. The bones aren't in line here. There's a very definite break going on here. So yeah, like I said, it's very common in kids and also in elderly osteoporotic females. If you see it in elderly males, then it's probably a very good indicator that they have osteoporosis, and you want to investigate even further in them with DEXA scans to have a look at their FRAC score and things like that. Management, generally, you can do a closed reduction and a cast. So a closed reduction just means that you're not opening any of the skin up, you're not doing any operations, and reducing it means you're putting the joint back into place. So this is generally done in the emergency department with some gas and air or some Entonox Penthrox. In children, we can do this in a lot of hospital departments with fentanyl up the nose, and we can also do it with ketamine sedations in A&E. Sometimes we will have to take children to the operating theatre to reduce it if they're not able to do it in ED through these methods. So yeah, we put them to sleep, put it back into place, and then cast them up. And that's usually just a below elbow cast all the way to the front for about 4 to 8 weeks, and then seen in clinic again. If the joint's really unstable or it's not able to be reduced in ED in a very good way, then sometimes we'll have to take them to the operating theatre, and we do what we call an ORIF, which is an open reduction internal fixation. So open reduction just means that you're opening up the skin to be able to get down into the bones, and internal fixation means that you're using maybe wires, plates, screws, those sorts of things to put it back into place. And then again, they'll be casted up and seen back in clinic following this. So that's one of the most common ones. That's a Colles fracture. And what I like to think is the opposite of a Colles fracture is a Smith's fracture. So where in a Colles fracture we had dorsal angulation, so dorsal meaning the back. If you think of a dorsal fin on a dolphin or a shark goes backwards. Smith's fracture, you have volar angulation, which means it goes forwards. So having a look at these x-rays here, do an ABCDE approach. If we go straight to B, we can see that there's a fracture here. We can't really see if it's displaced. It looks a little bit shortened. You can see that the radius has dropped compared to the ulnar, but we don't know from this view alone how displaced it is. That's why it's really important to get a lateral as well and we can see here, ooh, really displaced. If you have a look at the thumb, that's always a good indicator on the lateral as to where it is. So thumb is always going to be forward. So here you can see that that hand has shifted forward rather than backwards as it would in a colleague. So this is kind of the opposite again to a colleague's in terms of how you fall. Rather than fall onto an outstretched hand, it's a fall onto a flex wrist. And that is what pushes essentially your distal radius out, and you get that volar angulation from that. You tend to see it in, again, young men and also elderly osteoporotic females. And the management of this is very similar to how you would manage the last one of collies. So close reduction in ED if you can, with a below elbow cast for a few weeks, or if you're not able to do that, then we'd look at doing an ORIF again. In this case, just because of the way that the fracture buckles, there's a lot of stress here right at the front onto the carpal tunnel, and the carpal tunnel is where you have a lot of your ligaments and tendons that come from your bones, from your muscles in the forearm into your hand, and also where your median nerve mainly runs in. So a lot of the time, if you do not get a good union of this, you can narrow the carpal tunnel, and people can be a lot more commonly able to get things like carpal tunnel syndrome and even compartment syndrome because of that. Another type of fracture, which is similar to Colles and Smith's, is a Barton fracture. And the only difference with this really is that the fracture itself goes into the joint. So it's called intra-articular. Intra-articular just means it goes into the joint. So as we can see from these fractures here, particularly on this AP, the fracture itself goes right into the joint, whereas ones we were seeing previously just kind of went across. They didn't go into that radius carpal joint here. Okay, and the management, yeah, again, this is the same. Malunion can cause carpal tunnel once again. Hey, any questions about those forearm fractures first of all? I can't see the chat, so I'll give it a few seconds just in case anything comes up. Feel free to shout out as well, but I know sometimes it's a bit scary doing that. Nothing yet. Perfect. Okay, so scaphoid fractures. So scaphoid fractures are one of the most important carpal fractures that we want to look at, and that's for multiple of reasons. So this is our scaphoid here. As you can see here, we have a nice big fracture right in the middle of our scaphoid, which is known as the waist. So again, common fracture, and similarly, it's caused a lot of the time by a foot injury, so fallen outstretched hand. And people will come in a lot of the time complaining of pain in their anatomical snuff box, which is right in here, right about where that scaphoid sits. So there's three parts to the scaphoid. So we have the waist, which is where this fracture is. We have our proximal pole, so that's closer to our body, and we have our distal pole, which is up here. Now these x-rays are really interesting. It can be very difficult to actually see a scaphoid injury sometimes, and it can just be because of the way a patient's positioned, just how small the bone is and how tiny the fractures can be. So about 5 to 20% of them are often missed. And actually the nice guideline, first line imaging for a scaphoid fracture, a suggested scaphoid fracture, is an MRI, which never happens because MRIs are so difficult to get. But that's actually technically the advice from NICE. So if you get that in an exam, it should be an MRI first line. And this is really important because of the blood supply to the scaphoid. So it's actually a retrograde blood supply. So the blood supply comes in at one of the ends of the pole. I believe it might be the distal pole. About 80% of it, the blood supply to the scaphoid comes in and retrogradely travels back through the scaphoid itself. So if you have any injury to the scaphoid, you're really risking disruption to that blood supply and therefore a vascular necrosis of that bone. So avascular necrosis means you don't have any blood supply and therefore it dies itself. So these are really important not to miss. If you have an x-ray and you think clinically it might be a scaphoid fracture because you have a patient that's got anatomical snuff box tenderness, you're pushing on the thumb, which is pressing down from here onto the scaphoid, and they're getting a lot of pain with that, then even if you can't see anything on x-ray, the most important thing to do is just treat it as if it is a scaphoid fracture. So that would be doing a thumb spica or short cast, and then that should be re-image in 1 to 2 weeks. And that goes for whether you've diagnosed it or not. Sometimes you aren't able to get, if it's quite disrupted, you aren't able to get a good reduction on it, and you might need to do some operations and put in a little percutaneous screw like here, or K-wire, which is just a wire that's drilled in, or again, you might do an open reduction internal fixation. But yeah, these are ones not to miss. And if you clinically think a patient might have it, but x-ray doesn't show it, still treat as if it is. It's not going to do them any harm. The worst thing would be to miss it and they have a scaphoid that unfortunately dies. Okay, and other important wrist carpal bones, but not necessarily fractures, are some important dislocations. So we have lunate and perilunate dislocations. So our lunate bone was our second bone in from the radius. So we have scaphoid lunate. So lunate's called that because it normally looks like a moon, lunar. So this is a normal alignment of a lunate and capitate. So capitate sits on top of the lunate, a little bit like people might call it a cup of tea in a saucer, or I like to think of it as like a golf ball on top of a tea. So sometimes when you get dislocations of this because of, again, falls onto outstretched hands, you can get signs on x-rays that the lunate has either partially dislocated or fully dislocated. So these ones here are full dislocations. So on an AP view, you might get what looks like a slice of pie, where the lunate usually is meant to be. It's spun around, so it looks like a slice of pie. And here, where we had our nice saucer and our cup sat on top, or our tea and our golf ball, here we can see that the tea is completely gone, the saucer is completely gone, and our capitate's just sort of hanging around in midair. So that's a full dislocation. Here we have a partial dislocation where there's still some contact here with the lunate. It's partially slipped forward, and again just needs to be reduced back in. So again, for these, main thing you're looking for is reduction of the dislocation. Sometimes may need, again, open reduction and internal fixation for these. Well, so that's mostly our forearms and our wrists. If there's any questions, fire away in the chat and I can pick them up as we go along. Okay, so common hand pathologies. So first one we have is a boxer's fracture. And it's called this, unsurprisingly, because it happens a lot to boxers or people that like to think they can box. So it's a fracture of the fifth metacarpal neck. So this is our 1, 2, 3, 4, 5, fifth metacarpal neck. And just here you can see we've got a fracture straight through the fifth metacarpal neck. And it's caused by a direct blow with clenched fists. All your energy is going straight through that metacarpal here. And unsurprisingly, 95% of these are seen in young males. So the main thing for these, they can just be treated conservatively. If they're stable, they're not displaced, and we tend to just put them in a short buddy strap like this, or in a short arm cast with the fourth and fifth fingers strapped, which is called a short arm gutter splint. If they're unstable or displaced, then we would want to do a K-wire fixation, which is just a little wire that's drilled into the bone to keep it together. And again, we'll put this cast on top of it as well. So that is a boxer's fracture. Another fracture that we have is a Bennett's fracture, and this is the base of the first metacarpal. So going 1, 2, 3, 4, 5. This is number 1, and here's our base of metacarpal. So this is the fracture line here, if you can see it. So this is again our intra-articular fracture. So it goes into the joint here, and it's caused by forced abduction of the thumb. So a lot of the times you can get them if you're riding a bike and you fall off, that thumb's hyperadducted, and the same if people are driving and have a car crash, they go forward, their thumbs stay behind the wheel, hyperextended. With these fractures, if they're stable and undisplaced, then we would just put them in a thumb spica cast, which is just keeps the thumb stable for 3 to 4 weeks, or again, if it's not stable, operative fixation. It tends to be quite a theme with these. If they're stable and undisplaced, we don't operate. If they're unstable or displaced, we do operate. A Rolando fracture is very similar to a Bennett fracture that we just went through. It's just that this fracture at the base of the first metacarpal is comminuted. And comminuted means that it's in more than 2 parts. So it tends to be a bit of a 3-way fracture in this case. So here you can see there's kind of multiple lines going into this fracture. Again, this is caused by an axial blow to a partially flexed thumb. So it tends to be in a fist fight, partially flexed thumb, and tends to be a T or a Y shape. So here you can sort of see it could look like a T or a Y. These ones are unstable because they're in 3 parts. There's not a great chance that they're going to heal together very well. So it does need an open reduction and internal fixation. We have our joint dislocations as well of the little fingers. These are actually really common. So these can go either volar, which is forward, or dorsal, which is backwards towards the palm, towards the back. So these are usually hyperextension injuries. Again, hyperextended and flex off. And dorsal is a lot more common, so for it to go backwards towards the back of the hand rather than to have a volar dislocation. In these ones, your volar plate, which runs within your finger, can be avulsed, which means it can take off a little bit of the volar plate with it, and sometimes this does need to be fixed. Depending on where you are with hands, sometimes it can be the orthopaedic team that do them, sometimes it could be the hand team that do them. So in my trust, it's the plastics department that will take all the hands. In other hospitals I've been to as a med student, they would do them within the orthopaedic team. So the management with these, you can reduce them with a digital block. So that is a ring block within the local web space. So you'd use something like lidocaine or bupivacaine either side of the finger that you're aiming to get. So say it was our pinky finger, we'd inject into the web spaces either side, wait a few minutes for the nerves that will be supplying that finger to have gone numb, and then we can look at reducing it back into place. And then what we'll want to do is buddy splint it. So splint it with the finger next to it for a few weeks until it's much better. As I said, if there is a large avulsion where because of the dislocation it's taken off some of the bone alongside it, or the volar plate, then you will need to do a bit of an internal fixation with it too. Okay, gamekeeper's thumb. So this is your ulnar collateral ligament injury. So the gamekeeper's thumb is a bit of an old term for it, and it kind of came from, when I was looking it up, it came from when people used to go out shooting, say pheasants, and then used to break the neck of the game. And it was that repeated injury that will cause them to have what's called a gamekeeper thumb. Nowadays, it's more common in skiers, where their thumbs get trapped in the loops of the poles, or in breakdancers when they're breakdancing, obviously. So it's caused by a hyperabduction of the thumb. So again, thumb coming out, abducted, and causes an avulsion or a rupture of the ulnar collateral ligament, usually in this first metacarpal pharyngeal joint. So here you can see we have a little fragment here next to our thumb, which you don't normally have, and we can also see when we look at our alignment of the bones, that they aren't quite in line as we normally like them to be. There's a little bit of a step there and it slipped out. So we can see that there's definitely something going on with this thumb here. So yeah, as you can see, there's an avulsion fracture here, and there's some joint space widening and subluxation. So subluxation just means it's moved ever so slightly. It's not fully dislocated, it's just subluxed. The management of these is actually a 6-part classification, which I don't think you need to learn for your exam. So look it up in your own time if you're interested. But generally, they'll need surgical fixation if the joint is unstable, if there's a displaced avulsion fracture, like this one, or the presence of a sternal lesion, which is a kind of volar plate cum UCL injury within the tendon sheath itself that will need operative management to get rid of. Okay, and then other findings you might see on X-rays are arthritis. We often will do lots of X-rays and you'll see arthritis in anyone pretty much over the age of 60 at some point. So osteoarthritis, we tend to get at our distal interphalangeal joints. Also get it in our first carpal metacarpal joint. So this top one here is osteoarthritis. So you can see in the joints if we went through our A, B, C, D, E. So our alignment's pretty good in these. The bones themselves, if we were looking at the cortex, we can't really see any fractures going around. But if you were to look at the bone density, you can tell that they're not quite as thick and as white as some of the previous X-rays what we've been looking at. And then see if we look at some of the cartilage and the displacement. So all these are pretty much aligned. This one looks a little bit dodgy, but that's probably because of the arthritis. And D, the density of these bones, you can see they're not very dense, and E, anything else. So this is where we would look at our loss. So our signs on X-ray for osteoarthritis is loss. So loss of joint space. We can see these bones just look like they're sat on one another. So there's no cartilage left in these bones at all. So we'd see that in C. Osteophytes, you can see here we've got some outgrowings of bones as we go around. Subchondral sclerosis, so this is whitening of the kind of joint spaces. You can see that here, and subchondral cysts. You can't really see that as well on these X-rays. You'd probably need to see some bigger joints and see it a lot more blown up, but you'll tend to see little bits of cysts in joints. And for arthritis in the hands or the forearms, there's not really a lot we can do. A lot of it is physio and analgesia, and depending on where you are, you can get some corticosteroid injections a lot of the time into the thumb or the wrist, and that can help with some of the symptoms. Rheumatoid, on the other hand, tends to affect the metacarpal phalangeal joints here, which are these joints, and you test for that on an examination, usually by an MCP squeeze like that. So the X-ray signs you look for RA is spades. So any soft tissue swelling, you can see there's some swelling around the knuckles here. Periarticular osteoporosis, so that means right next to the joint you can see some loss of bone. So here you can see the bones aren't quite as white and as dense as they are a little bit further down into the bone. Absent osteophytes, so they won't tend to get osteophytes. Deformity, you can see these bones are looking quite crooked. And not as straight and nice as we like to see them. And then erosions and subluxation are late features. So you'd see erosion of the bone, and also, as we said, subluxation is just where the bones start to shift on top of one another. They're not fully dislocated, but they start to shift away. Other things that we can look out for are infection symptoms. So you can have a look at osteomyelitis on an X-ray. It's not always the easiest. We tend to go for MRI to help with our diagnosis of this, but on X-ray you might see some osteopenia around the joint itself. You might see some loss of the bone trabecula, which is just that fancy architecture of the bone. You might see some thickening, and you might see some bone lysis, which is where the bone starts to crumble away. As you can see, just at the top of the finger here, it's starting to fade away a little bit. Septic arthritis, you can't really see much on an x-ray. You might tend to get narrowing of joint space or effusion, but you don't really tend to see much. It's a lot more of a clinical diagnosis with your hot, red, swollen joint and fever and restricted range of movement. So if you see that, first thing you want to think of is septic arthritis, and that's one of your kind of orthopedic emergencies. It's a rapid intra-articular infection. And then another one is infections, tender synovitis. And this is where you get an infection within the synovial tendon sheath itself. You won't see much on an x-ray. Again, it's mainly clinical, but we can see it on ultrasound. You might see some soft tissue swelling and gas. And for these ones, you definitely want to operate on. They need to have that tendon cleared out pretty ASAP. Okay. So if anyone has any questions about hands, feel free to put them in the chat. And if not, we'll have a look at some pediatric considerations that we should have as we go. No, okay, fine. So pediatric considerations. So as I said a little bit earlier on, growth plates is probably one of the biggest things to think about in pediatrics. So when we're all young and growing, our bones need to grow in some way, so we need to have growth plates to allow them to grow. So this is what they look like here. And as you can see, they could be mistaken for fractures pretty easily, but it's important not to see that. And one of the things about these growth plates is that you can have fractures through them. And depending on what type of fractures they are, they can either be good or they can be quite bad. So the things that we want to look out for to know our classification of Salter-Harris growth plate fractures is type 1 to 5, and an easy way to remember is literally Salter. So Salter-Harris, but without the E. So this is what our normal bone would look like. Here, you'd have to kind of imagine it upside down. So up here is our proximal joint. This is our distal bone. Here, this is our proximal bone. This is our distal bone. So type 1 is S-slipped. So that is where a fracture kind of goes just straight kind of through the growth plate here. It can be quite difficult to see on an x-ray. But you see some slipping of the growth plate here, and that indicates the fracture's just gone straight through. Usually they're pretty okay. You can manage them conservatively, and they don't need much doing to them, and you have a good prognosis for healing as well. Type 2, you have a fracture above the growth plate. So this is our proximal bone. This is our proximal bone. Here you can see we have a subtle fracture here. Got a break in the cortex. Now fracture just running through. But we can't see it running anywhere else. So we can pretty happily say that the fracture's gone through the growth plate and up above the fracture, above the growth plate side. So that's our above fracture. These again have pretty good prognosis. They heal pretty well. They don't tend to need surgical intervention for them and don't tend to have much an effect on later bone growth. Type 3 is our L for lower. So this is where you get a fracture below the growth plate line. So this is into your epiphysis rather than above. And here you get a bit of a worse prognosis because you've had the fracture come through and down into the epiphysis, and that's going to disrupt some of that ongoing bony growth. And type 4 is through. So you'd have a fracture all the way through both sides of the growth plate. And again, that's got quite a poor prognosis in terms of how it heals and how you can go on to grow further on. Type 5 is the worst one. This is a ruined or a rammed situation where basically you've had an injury that's smashed the growth plate together. The growth plate's completely closed. There's going to be absolutely no growth from this. This is the worst prognosis ever. So 3 and 4, it's pretty hit and miss prognosis. Type 5 is the worst prognosis. And this is important because you can get stunted growth. Say you fracture your right arm when you're 5 years old and you have growth plate injury, that's a type 5. Your left arm doesn't have that. At 5 years old, your radius is going to stop growing. Your ulna is going to carry on. All the rest of your bones are going to carry on. Your left arm's going to carry on. But what you start to get then is deformity in that right arm where you've broken that radius. And it's very difficult to manage. So these are things that you need to be aware of when you see pediatric fractures, managing them accordingly and making sure that they are seen as soon as they can. Other fractures that we can look at in paediatric patients that don't tend to happen in adults are buccal or porous fracture, and that's an incomplete fracture of a shaft of a long bone. And we see this as a bulging of the cortex. See how this one's nice and smooth. This one here, oh, we've got a bit of bulge. We've got a bit of a bulge. So we can't really see too much of a fracture line, but we can see that the bone has been compressed and is started to bulge out. This is tended to be caused by an axial loading force, so like falling from a height, those sorts of things. There was a big study a few years ago that found that actually you don't really need to do much for these. They are self-limiting. We can put patients in a splint or a cast just to make them feel a bit better, but rest and immobilization is the thing that's going to keep them well rested and recovered. Okay, and other fractures that we tend to get are supracondylar fractures, and these are included in the Gartland classification. So our supracondyles are on our humerus bones, so up here, and interconnect with our olecranon and our radial head. When we get a fracture of our supracondyles, there's 3 types. Type 1 is undisplaced, type 2 is partially displaced, and type 3 is completely displaced or off, and then 4 tends to be comminuted. Usually type 1 we can leave in an above elbow cast, so cast from here all the way down, and they can be managed conservatively. And then from memory, 2, 3, and 4, we have to manage with an operative management for them. Other signs we can look out for on the supracondylar fractures are fat pads. So we talked about at the beginning if there were any other deformities or extra features that we wanted to look out for, densities and things like that. Then fat pad swellings are ones that we can see as well. So if you can see on this anterior side of the humerus, we've got this little bit of a shadowing here, which is a different color to this kind of subcutaneous skin. We've got a little bit of darkening here, and then also on the back we've got some darkening here, and these are our anterior and posterior fat pad signs. Anterior fat pad you can see in some cases where there's just been some soft tissue injury and not necessarily a fracture, whereas a posterior fat pad sign is pretty much always a guarantee that there's going to be a fracture somewhere in there. So it's worth keeping an eye out for those things, and they can give you good indication as to whether there's a fracture there if you're not totally sure. Okay, so let's go through some case scenarios. So before we go through these in the last 10 minutes, has anyone got any questions just before we crack on about anything we've gone through so far?
I was just wondering, in terms of analgesia, what's the first line?
Is this for what type of patient? For like arthritis or for fractures?
Oh, sorry, I meant fractures.
Fractures. So it really depends on how badly they're feeling. So generally, if it's once patients have got their fractures immobilized and in a cast or fixed, the analgesia isn't really needed as much. The main thing that's causing this pain is these broken bones kind of rubbing around against each other. So a lot of the time when they first come into hospital, the first thing that they'll probably have is probably some oral morphine, so oral morph. We tend to give them some of that, but also looking at your general paracetamol regularly as well. You tend to want to avoid NSAIDs, so things like ibuprofen and naproxen, because there's some studies that this can be bad for bone healing. But yeah, I'd say in the first instance, oral morphine's really good for patients. Once they have their fracture fixed and immobilized, then you can look at stepping them down. And most of the time, patients will go home with maybe a bit of cocodamol or even just paracetamol, and they're able to cope like that.
Okay, thank you. And is the oral morphine, is that all right for children as well?
We can give it. We don't tend to give it as much. You can give it in just lower doses. Children tend to get a bit more side effects from the morphine, so they tend to get a lot more of the nausea and can sometimes have hallucinations and things like that, and they get a little bit funny with it and can be sick. So we tend to steer off that. Sometimes we'll give maybe cocodamol for children in low doses, but again, it's usually going to be Calpol for them and loading them up. Once you've got them in a cast, they're pretty good. And for kids, as with pretty much anything, distraction therapy works absolutely wonders. If you've got their favorite toy, their favorite TV program, you're distracting them, you've got some glitter on their cast, they're usually quite happy once that's done.
Okay, thank you.
It's okay. Any other questions at all? Either in the chat or you can shout them out. No, okay, I have another message. So let's do a couple of scenarios before we end. So we have a 68-year-old female with a fall on an outstretched hand. So these are the three things that I want you to think about. So what does the x-ray show? What's the diagnosis? And what is the management? So go through your A, B, C, D, E for this patient, see what you can notice. What do you think the diagnosis might be? And then what the management may be from that. If anyone's feeling very confident, then either put it in the chat or feel free to shout it out loud. I'll give you a couple of seconds. Okay, so for this one, this showed us a dorsally angulated distal radius fracture, so which is our very infamous Colles fracture. So if we have a little look, particularly on our lateral, we can see the bones come up. We've got a shift backwards, so we can see our thumb here. Our thumb usually sits forward, so we can see that our hand has shifted slightly backwards. So that's dorsally angulated, and we've got our fracture here, right in our distal radius. And yet management for this, if it's stable and it's okay, then we do close reduction and a cast, or if it's displaced or unstable, then we would look at doing surgery. So well done if you got that. Okay, the next one, we have a 7-year-old child that's fallen off a swing and landed on their elbow. And on examination, they've got a lot of pain and swelling in that elbow. So again, what does this x-ray show? What do you think the diagnosis might be? And how might we manage this patient? So again, I'll give you a couple of seconds. All right, so we have a displaced supracondylar fracture with a posterior fat pad. So posterior fat pad, using your eye of faith, is here. It's ever so slightly subtle. And if you think about it, in real life, you'll be seeing x-rays on decent computer screens that have effects where you can go up and down so you can see tendencies a bit better. So this is a Garland type 3 fracture, and it's a supracondylar fracture of the elbow. And again, for this, we'd want to do a reduction and a pinning for this. So pinning with K wires, big cast above elbow all the way down, and let it heal. Okay, so in summary, we've gone through a systematic approach on how to look at x-rays, and this is really key in not missing anything. You'd be surprised by you're looking at say a shoulder x-ray and you've completely missed the fact that they've got a pneumothorax in their chest whilst you're looking at it, or clavicle fracture that goes along with a humeral fracture. So definitely when you're going through your x-rays, really take a lot of time to go through them really methodically. We've had a look at some common fractures and dislocations and looked at why it's important to check alignment and soft tissues, and why and when to suspect hidden injuries. So scaphoid fractures are really important. And then there's just a little plug for SynapseUK WhatsApp, so feel free to join. I'll leave that up there for a second. And if anyone's got any questions, then feel free to shout them out, pop them in the chat.
Okay, hello everybody. We're going to talk about elbow and forearm x-rays and some basics of interpretation and common pathologies. My name is Dr. Sajid Butt. I'm a consultant radiologist at the Royal National Orthopaedic Hospital in Stanmore. So the common pathologies in elbow, obviously it's a part of the body which can get fractured. And there are basic principles which we have to keep in mind when interpreting or trying to interpret the x-rays. In the elbow joint, you obviously have to look carefully at the outline of the cortex of various bones and see if there is any break in the continuity, which would signify the presence of a fracture. And the fracture lines, you can have black fracture lines, which is meaning that there is a bit of a distraction of the fractured bone margins, or you could have a white fracture line in which the fractured bone ends have actually impacted against each other. In addition to the break in the cortical outline, there is the presence of soft tissue swelling in and around the elbow joint, which is a good indicator of a significant trauma. And those flat pads within the elbow joint, they can be raised, giving rise to signs of joint effusion. And when you see those, you have to carefully look at the cortex again, preferably by zooming it up to make sure that there's no fracture. The usual mechanism of injury is fall on the outstretched hand. And when you go on to treating these, you have to obviously immobilize in a sling. And if there's a minimal displacement, and if there is a significant degree of displacement, then you have to consider getting the fractures internally fixed. Okay, next slide, please. So here's an example of a lateral view of an elbow. This obviously is the radial head, and you've got the olecranon, and there's a fracture of the olecranon. Because of the strong pull of the triceps, the fractured bone margin can be pulled proximally. And the fracture line, that can be an impediment in fracture healing, because for the fracture to heal, it has to be right next to the bone from which it is separated. So if there's a lot of distraction, then it needs to be fixed internally. Okay, next slide. Whenever there's a fracture, you have to look carefully at the injuries of the surrounding soft tissues. And in case of elbow, these are the blood vessels, which take blood from the upper arm to the lower arm, hand and wrist, and the three important nerves, which are very closely related to the elbow joint: the median, the radial, and the ulnar. The management is immobilization in a sling. You may have to apply a splint. And in cases of displaced, like I said, you may have to fix them internally. Next slide, please. Here's an example of a posterior elbow dislocation. When you're describing the dislocations, it's the relationship of the distal part of the fractured bone, which you have to count that as. So because distally, the olecranon has clearly pushed itself further posteriorly, that would be called a posterior dislocation. And it's the triceps pull which does the trick. Hence, posterior dislocation is more common. In order for this to heal, obviously the dislocation has to be reduced, and then the patient treated in a sling. Next slide. The flat pad signs are indicative of intra-articular effusion, and they usually mean a significant degree of trauma. So here we can see that normally you can just about see the anterior fat pad, and posteriorly we may or may not see a fat pad. But in case of effusion, the anterior fat pad is raised away from the cortex. And when you see that, very carefully analyze the bones, and you have to mag it up. And when you can't see a fracture, ask for help. That's a crucial point. Another important point to remember is that when you see a fat pad being raised, that means a fracture. But if you don't see a fat pad raised, that does not mean the fracture is ruled out. A fracture could still be present, and that has to be carefully ruled out in case of significant trauma. Next slide, please. Elbow joint can be affected by osteoarthritis. And the hallmarks of osteoarthritis are joint space narrowing, which is usually irregular, presence of osteophytes, and the formation of subchondral sclerosis and loose bodies. You can also get subchondral cysts, which are called geodes, which mean presence of liquid in a subchondral distribution. Next slide, please. Patients usually present with pain and stiffness and reduced range of movement. They may have crepitus on trying to move the elbow joint, articulating bones. Osteoarthritis is the commonest disease affecting humankind, and as we grow older and older, the degree of osteoarthritis increases. There are various conservative methods of treatment, like treating patients with non-steroidals, trying to use intra-articular injections of steroids and gels of hyaluronic acid preparations. Very rarely, you may then have to do surgical repair, in which a new joint is put in. This is uncommon in terms of elbow, very common in hips and knees. Shoulders also get replaced quite commonly, but not very commonly performed for elbows. Next slide, please. So when it comes to fractures, you can have isolated fractures of either radius or ulna. And one of these is the fracture of the ulna, which normally happens because of direct trauma. Patient could be assaulted, and when they're trying to defend themselves, they are hit by hard objects like a stick or a baton, and they could have a fracture. Hence the name, the nightstick fracture. Next slide, please. This is a common injury, Montague fracture. It is a combination of two. So you've got a fracture of the ulnar shaft, and along with that, there is a dislocation of the superior radial joint. Usually, patients get injured by fall on the outstretched hand and a direct trauma. So the fracture has to be reduced, may require internal fixation, and don't forget the sublux superior radial joint. Next slide, please. It can be a significant trauma, and obviously you have to worry about injury to the neurovascular structures, and hence quick treatment is required. Not very easy to miss such significant injuries. The only thing I would stress upon is that when you see the obvious ulnar shaft fracture, remember to include assessment of the superior radial joint. Next slide, please. Let's is the opposite. So it's a fracture of the radial shaft and dislocation or subluxation of the distal radial joint. Again, the same things apply, which we talked about Montague. Significant trauma would require fixation, reduction, and relocation of the distal radial joint. Next slide, please. You can end up with chronic distal radial joint instability if the joint is not relocated, and you may require internal fixation for the radial fracture. Next slide, please. This is a relatively uncommon complication of trauma Following injury, you can have hemorrhage within the muscles, and then that heals by forming ossification. Usually, the ossification in the soft tissues happens in a shell-like pattern, and sometimes it's very difficult to see that shell-like pattern initially. So when in doubt, we tend to do a follow-up scan, and then later on, it becomes more organized and relatively easy to identify. They're usually not biopsied because the biopsy interpretation can be difficult. And sometimes people mistake them for malignant tumors. They're not malignant. When you see this shell-like pattern, which is also called zoning, that's very typical of myositis ossificans. Next slide, please. Patients present with pain and swelling and stiffness and a soft tissue lump. There can be a restricted movement depending on the size of the problem, and depending on the exact location, you could have nerve compression. It is treated conservatively, and very rarely surgical excision is needed. Next slide. Green stick fractures are identified usually in children, and the reason is that the children have very bendy bones. They're soft, and therefore when they break, they don't break like a hard stick would break because of the bendy nature, like a green stick of a tree. They could fracture only from one side and the other side being intact. It's a typical injury pattern in kids, and you just have to recognize that this will happen. Treat it conservatively because children have excellent healing potentials.